The next speaker is Dr. Blaes. Ann is a professor in hematology oncology at the University of Minnesota, where she also serves as the division director of hematology, oncology, and transplantation. She's the director of the Cancer Survivorship Services and Translational Research Program and co-director of the Screening, Prevention, Etiology, and Cancer Survivorship Program within the Masonic Cancer Center. Dr. Blaes is an active hematologist, medical oncologist with a special interest in breast cancer, cardio-oncology, and cancer survivorship. And Dr. Blaes is a national and internationally recognized leader in this field. So welcome.
Thanks for having me here today. This is a topic near and dear to my heart as I think about survivorship from a medical oncology perspective. And you'll hear some common themes from our speakers earlier today, and hopefully I can tie some of that together as I think about it from a medical oncology and a survivorship perspective. I'm going to talk a little bit about the changing paradigm in GI malignancies, and we've heard a little bit about this, the toxicities from chemotherapy and immunotherapy, and then really the unique impact on the adolescent and young adult population when we think about survivorship. So we've heard already today, and many of you are very familiar with the fact that the backbone of GI cancer therapy really requires a multimodal approach consisting of chemotherapy, surgery, radiation, particularly in rectal cancers, targeted therapies in select situations, and even in a smaller subset, immunotherapy. And I think as we've heard here as well today, compared with the older cohorts, more patients with early onset colorectal cancer are given adjuvant chemotherapy, really suggesting, as we've heard, that people want to be aggressive, patients tolerate treatment, and are also fearful that patients are going to have recurrence, where it's not actually clear that that extra therapy improves their overall outcomes. So how is the field actually changing in colorectal cancers? And we've heard a little bit about this, but I wanted to highlight a couple of different studies. One, we heard a little bit about the Prospect study that was just reported at ASCO this year, asking the question about the role of chemoradiation in those with lymph node positive and high risk locally advanced disease, which really asks the question whether those who have the standard of care, pelvic chemoradiation, followed by surgery, followed by adjuvant chemotherapy, whether or not we actually can omit chemoradiation in this patient population. Within this trial, the primary endpoint was disease-free survival, looking at a slew of secondary endpoints. And I think as we've heard, there was a non-inferior overall survival at a median follow-up of 58 months. There was also no difference in local recurrence-free rates, suggesting that some patients who respond exceptionally well to chemotherapy may not actually need chemoradiation. You saw this slide earlier, really suggesting that at least sexual function, when you look at both male and female sexual function in survivors, tend to have less impairment when they've not received chemoradiation. What about the role of surgical resection? And the Oprah trial that was reported out looked at this question of whether if patients have had an exceptional response to chemotherapy or chemoradiation, could they go on a watch and wait protocol as opposed to going on to total mesorectal excision? Within this study, about 3/4 of the individuals were offered a watch and wait protocol and did not initially go on to complete surgical excision. 1/3 of those developed regrowth and then went on to surgical excision. And in the bottom graph, what you can see is that there was no difference in disease-free survival, whether they underwent total mesorectal excision at initial, at restaging, or at regrowth, with 5-year disease-free survivals at 64%. And we're going to hear later on today about the magnificent response in a certain subset of individuals to immunotherapy. Within this landmark publication, they looked at PD-1 blockade in those with mismatch repair deficient locally advanced rectal cancer. And while this is a small prospective phase 2 study, They looked at the use of dostarlimab in patients with mismatch repair deficient locally advanced stage 2 or 3 rectal adenocarcinoma. And all of the patients within this study, in this small subset, had a clinical complete response by 6 months. None of these patients received chemotherapy or chemoradiation or surgery. And clearly longer follow-up is needed to know whether or not this is going to be durable. But it's very exciting as you think about it from the survivorship perspective, really asking the question that is the paradigm of treatment changing, and will it be changing over time? So when I think about things from a survivorship perspective, I would say the standard of care has been chemoradiation followed by surgical resection and chemotherapy. But hopefully I've showed you some data that in select cases, radiation may be avoided. In select cases, surgery may be avoided. And we're starting to think about the fact that in some situations, perhaps all of these can be avoided. And clearly we need longer follow-up. I think whether or not these are actually adopted for younger patients, as we heard earlier, some of this comes down to trade-offs. Some of this comes down to conversations with the patient. But I think when I think about things from a survivorship perspective, you can imagine the person who has received IV immunotherapy only is going to be at a very different risk profile in the long-term follow-up period compared to somebody who had chemotherapy, radiation, and surgical resection. So who's at risk for late effects from their cancer therapy? Well, a lot of this depends on the type of treatment somebody had, whether they did have radiation, what kinds of chemotherapy, did they develop complications during the course of their therapy, and what kind of pre-existing medical conditions did they have when they came in. But this is all impacted by other factors such as age and gender, the lifestyle factors, as well as genetic factors in thinking about our patients. So from a medical oncology perspective, thinking about the backbone of treatments for GI cancers, most of these patients will receive 5-fluorouracil or oral capecitabine chemotherapies, oxaliplatinums, irinotecan, in some situations, targeted therapies such as EGFR inhibitors or VEGF inhibitors. Rarely in upper GI cancers, anthracyclines are used, and in a small subset of those with advanced disease, HER2 targeted agents. And as we mentioned, there's a small subset of mismatch repair deficient tumors that are very sensitive to immunotherapy. So what kinds of late effects do patients actually have when they're receiving these treatments? We saw this figure earlier. So this was a cross-sectional study by Bailey and colleagues really looking at what kinds of symptoms do survivors actually have and are still complaining of 10 years after their cancer diagnosis. As you can see, about 80% of them are still noticing changes in body image. 60 to 70% having anxiety, and between 40 and 50% will complain about changes in male and female sexual function. The blue bars are really looking at those who develop young onset colorectal cancer, where body image changes were particularly significant, as well as anxiety. Many of them complain as bowel functions, as we just heard. This is particularly around micturition problems, abdominal and pelvic pain, bloating sensations, hair changes, as well as embarrassments about bowel movements and impotence. I think about long-term medical oncology effects. We give lots of drugs like oxaliplatin that cause neuropathy. Most of our clinical trials would suggest this is at rates of 10 to 20%, although some studies would suggest this is as high as 60%. And for adolescent and young adults, what about fertility and premature menopause? 5-fluorouracil has been known to reduce sperm count and induce amenorrhea. This has been felt to be temporary and the permanent risk to be low. Oxaliplatin, irinotecan, as well as a number of the targeted therapies, there's actually very little data that exists on long-term impact. We heard a little bit about the fact that radiation to the pelvis, however, does encompass the ovaries and uterus, and prostate and gonads, which can result in infertility. And I would say working with a lot of young adults in our clinic, this is a huge concern for patients and oftentimes is not addressed well at the time of diagnosis and remains a long-term risk for them. Risk might not be the right word, but a long-term anxiety, it impacts their quality of life, both from the fertility perspective, but for those who go into menopause with their treatment, symptoms related to that. What other chronic health conditions do we think about in our long-term survivors? I would be remiss if I didn't talk about heart health. In the figure on the top, we heard a little bit about this from Dr. Freyer earlier today. But when you look at 10, 20, 30 years out from diagnosis, adolescent and young adult survivors have elevated risk of cardiovascular mortality, about 1.4-fold over the general population. This risk is highest when you look at individuals like Hodgkin and non-Hodgkin lymphoma survivors. But even in young adult GI cancer survivors, the standard mortality ratio is approximately 1.2, with an absolute excess mortality of 2.3. As I mentioned, most colorectal cancer survivors do not receive anthracyclines and rarely receive HER2-targeted agents. Some of the upper GI cancers do receive those, and their long-term cardiac risk is different. And I just steer you in the direction of the Childhood Cancer Survivor Study has a tool that looks at cardiovascular risk calculators that can be used particularly for those who've received anthracyclines. This was a recent publication looking at young adolescent survivors, so in their 15 to early 20s, by Tara Henderson and Sue and colleagues, published in the Lancet Oncology. And the dark black lines are the adolescent young adult survivors, which in the bottom bars, you can see increases of excess cardiac disease, second cancers, as well as overall health conditions. We talked a little bit about this yesterday, but many people wonder, well, why are we seeing more heart disease and more second cancers in our adolescent and young adult cancer survivors? And there are hypotheses and some early data to suggest phenotypes of accelerated aging. This is a figure that shows an individual having a cancer diagnosis. Many patients will have a functional capacity decline and changes in their VO2 max during that time period. And what you can see in the blue bar is sort of the normal aging trajectory. And many of the hypotheses right now is this phenotype actually changed and individuals actually go through an accelerated aging process? I think we have a lot to untangle in here. One, how do lifestyle things, can they actually move people back up on the trajectory? We've heard about the microbiome today, and I'll come back and talk a little bit about that. Our group has gone on to try to measure some of these aging metrics. There are markers of cell senescence that are detectable in the blood. There are proteomic changes. And part of my colleagues, Dr. Anna Prisman and Shua Wang, have looked at proteomic aging clocks. And these actually can predict mortality in cancer survivors by about 1.5-fold higher. And you'll see in the bottom part of this, about a 2-fold higher mortality in colorectal cancer survivors. This was adjusted for age, sex, race, as well as physical activity and some habits. I will say this particular data is not unique to adolescent and young adult survivors, but does encompass them. And what about immunotherapies? Well, when we think about the adverse complications of immunotherapies, this is really a new spectrum of adverse events. These immune-related adverse events occur through an imbalance of tolerance and drug-induced immunity. We saw a similar figure from Dr. Freyer earlier today, talking about long-term complications from chemotherapy. When I think about immunotherapy, I think about lots of itises. Endocrinopathies such as hyper and hypothyroidism, adrenal insufficiency. Many of us are familiar that practice in oncology about these occurring acutely. So I think the median average, they occur 5 to 12 weeks after starting treatment. Our recent data would suggest, however, that about 10% of them actually occur after stopping immunotherapy. And what do we know about some of the things that affect our adolescent and young adult survivors? For example, what do we know about immunotherapy and fertility? Well, given that most immunotherapy has been approved in the metastatic setting, there's actually very little data on the effects of immunotherapy on fertility. You can hypothesize that there are a number of potential mechanisms, such as primary hypogonadism and secondary hypogonadism. But direct gonadal toxicity related to immune checkpoint inhibitors has not been reported. I was able to find some preliminary mouse model data that suggests immune checkpoint inhibition actually increases immune cell infiltration and tumor necrosis factor expression within oocytes. In animal models, it diminishes ovarian follicular reserve, and it impairs the ability of oocytes to mature and ovulate, really suggesting for me as a medical oncologist, when we're using more immunotherapy upfront, it really makes me ask in the curative intent setting, how is this going to impact patients long-term? And what about immunotherapy and cardiovascular disease? Recent multivariate analyses has demonstrated a threefold higher risk of cardiovascular events after starting immune checkpoint inhibitors. There are imaging data and some animal model data to suggest increases in aortic plaque volume after the administration of immunotherapy. And in animal models, PD-1 and the PD-L1 pathway actually downregulates the pro-atherogenic T cell response, which really can lead to upregulation of genes involved in cholesterol synthesis. There are a couple ongoing R01s right now trying to unpack this. Javed Mosahi and the group at UCSF have trials to really try to understand the pathogenesis and whether this is a real phenomenon or what this means long-term for our survivors. And I think I would be remiss if I didn't talk about some of the other things we're going to hear from Dr. Salsman about the psychosocial impact on our adolescent and young adult survivors. But I think it's really important that we also mention that all of the cancer therapies, surgery, the impact on our AYA population, financial toxicity is a huge thing to address. This was a recent systemic review looking at publications between 2010 and 2022. While educational attainment did not differ in AYA survivors compared to the general population, there was a higher likelihood of unemployment. There was lower income overall and higher rates of utilization of Social Security benefits for income supplementation than the general population in adolescent and young adult survivors. And those at highest risk for financial toxicity are those in the lowest income quartile, our Black Hispanic population, as well as those who underwent surgery for colon and esophageal cancers. So how do we stay well after having a cancer diagnosis? And oftentimes I talk to patients about the fact that we can't change the fact that they went through their treatment. They received therapies such as chemotherapy, radiation, immunotherapy. I mentioned to you that the kinds of treatments patients had, whether or not they needed certain drugs, certain radiation fields as part of their treatment, is really important. There's a lot of controversy on the survivorship care plan and the utility of them. And Dr. Freyer alluded a little bit to this, but I do think patients need to know what they've had in some way, shape, or form. For those who've had complex exposures, particular radiation, they're treated at very young ages. They've had complications from their treatments. Consultations in cancer survivorship clinics, I do think helps not only the patient, but also the primary care provider. And in adult oncology, many of these patients are seeing primary care, and that's where they're going to stay long-term. So I think figuring out how do we engage our primary care providers to be aware of these risks in the long term, I think is important. And finally, thinking about lifestyle medicine, we've heard about the microbiome this morning, but when we look at colorectal cancer survivors, we know that exercise and adequate sleep are really important. This was a publication a couple of years ago and has been replicated in several others, that higher rates of exercise by quartile has actually less cancer recurrence. Similarly, having adequate sleep of 6 to 8 hours a day in this CALGB study of colorectal cancer survivors was associated actually with improvements in disease-free survival. And I wanted to highlight this other, looking at adolescent and young adult survivors who've developed comorbidities such as chronic conditions, risk for second cancers, cardiovascular disease. What this figure shows you is that if individuals are participating in healthy lifestyle, and they called these lifestyle variables that they looked at smoking status, alcohol use, physical activity, and body mass index. Healthy lifestyle and the absence of hypertension and diabetes were each associated with a 20 to 30% reduction in health-related mortality. Importantly, the effect of unhealthy lifestyle on mortality was independent of other modifiable cardiovascular risk factors. And these are things we can do something about. We have to do it in partnership with our primary care providers and our patients. So in closing, as you think about a cancer survivor, this outer ring is really thinking about all the physical effects of their cancer treatments from a medical oncology perspective. There are many other things, though, that impact the cancer survivor, such as finances, psychosocial, spiritual health, as well as role disruption. And we're going to hear about that from Dr. Salsman. ASCO, a couple of years ago, came out with a specific cancer resource list for primary oncology providers focused on adolescent and young adults. I like to think about this as a checklist for adolescent and young adults. And really the key takeaways are asking about fertility and sexual health, genetic testing, addressing financial toxicity and psychosocial concerns, and then really thinking about lifestyle interventions. So in conclusion, there are unique needs of AYA-GI cancer survivors. Treatment characteristics impact the risk for long-term complications. There is, however, still a gap in knowledge of how to risk stratify survivors and their risk of these complications. And I think lifestyle medicine is essential in the care of AYA-GI cancer survivors. I didn't go through some of the details today, but we really need to do further work in diverse populations. I briefly mentioned the financial toxicity being different in our Black Hispanic populations, as well as our lower incomes, and really think that this is important when we talk about next steps on the research side. And finally, that's Goldie Gopher. I'm from the University of Minnesota, and what we like to say is we need to go for a cure. So thanks for having me.